Okay, so let's go to your lesson 6 class. For lesson 6, we have the urine screening for metabolic disorders. Now, whenever we would talk about metabolic disorders, we're talking here about the metabolic processes wherein the urinary system or the urinary system is technically involved. So there are two types of metabolic disorders class: the overflow and the renal disorders. So whenever it's overflow, take notice that this would involve the disruption of a normal metabolic pathway, increased plasma concentration of the non-metabolized substances, overrides the absorption ability of renal tubules, inherited lack of specific enzyme for protein, fat, or carbohydrate metabolism. There would be inborn error of metabolism. While for the renal class, there would be malfunction in the tubular reabsorption mechanism. So take note of the difference between overflow and renal class. To simplify, ang renal nyo, there's a problem with the reabsorption ability of your kidneys. While overflow, they tend to be higher amounts of solutes in the blood. So there's what we call inborn error of metabolism. So may mga enzymes, there are enzymes that are missing or absent, leading to these problems. So these are the disorders classified by defect. So we have the overflow that is inherited. Under overflow that's inherited, we have your PKU, tyrosinemia, alkaptonuria, MSUD, organic acidemia, cystinosis, porphyria, mucopolysaccharidosis, galactosemia, and Leishmanian disease. For metabolic, we have your infantile tyrosinemia, melanuria, indicanuria, 5-hydroxyindole acetic acid, and your porphyria. For the renal, we have your heart valve disease and cystinuria. So let's talk about first the phenylalanine or tyrosine metabolic pathway. So this phenylalanine-tyrosine metabolic pathway is one of the current state mandated screening for as many as 30 or more inborn errors of metabolism. So if there's a problem with your phenylalanine-tyrosine metabolic pathway class, there is a possibility that there could be 30 or more IEMs. So what you would use to test this is urine testing, which are used for follow-up. Disorders can cause abnormal urinalysis result. But the identification test for this is your heel stick blood test. So heel stick blood test class are usually done for newborns. Usually done before the newborns are allowed to leave the hospital. But it could also be done greater than 24 hours. Metabolites would appear first in the blood. So familiar kayo class sa heel stick, di ba? Yung one way of collecting blood from newborns is via the heel. So gagamit kayo ng feather lancet, then you wipe off the first blood, then you would dip it or you would blot it. Iba-blot mo siya against a cardboard. Yung cardboard na yun yung sa newborn screening glass. So ganyan yung tsura niya. Tapos may mga bilog-bilog dyan. So you need to blot the blood to those circles. Analyzed by tandem mass spectrometry. So tandem meaning dalawa, mass spectrometry, MS. So it's being analyzed by your MS or your tandem mass spectrophotometry. So here we have your phenylketonuria, tyrosiluria, alkaptonuria. Now, phenylketonuria class would occur in 1 in 10,000 to 20,000 birth. Autosomal recessive, heterozygotes normal, eliminate phenylalanine from diet, usually milk. So bawal mag-milk yung baby class or yung newborn or yung bata. It can lead to damage to the child's mental capacity. Alternate pathways as the child would mature. Avoid increased phenylalanine foods, such as those foods with high amounts of aspartame. So that's your PKU. Now, the problem or the cause of your phenylketonuria is the absence of the enzyme phenylalanine hydroxylase. So you would use urine test. Urine and 5% ferric chloride would produce a permanent green-blue color. Then we have your tyrosiluria or tyrosinemia. So this is a metabolic defect, premature transient tyrosinemia. This can cause underdevelopment of liver function, acquired severe liver disease. So there are hereditary defects of tyrosiluria. So there would be type 1 tyrosiluria class or tyrosinemia. There would be enzyme deficiency. So the enzyme missing here class is your fumarate acetoacetic acid hydrolase. Can lead to renal tubular disease and liver failure in infants. So the hereditary defect of tyrosinemia is type 1. So type 1 tyrosiluria and tyrosinemia is caused by the absence of the enzyme fumarate acetoacetate acid hydrolase. Then the type 2 naman class, which is a hereditary defect. So type 2 and type 3 naman are hereditary defect. For type 2 class, this is caused by the deficiency in the enzyme tyrosine aminotransferase. Can lead to corneal erosion, and lesions on hands and feet. While for type 3, this is caused by the deficiency of para-hydroxyphenyl pyruvate oxidase. Can lead to mental retardation if no dietary restriction. Screening test would use tandem mass spectrophotometry available for tyrosinemia types 1, 2, and 3. So do memorize class the enzyme deficiency of type 1, type 2, and type 3 tyrosinemia. Then we have your melanuria. So melanuria is the second pathway for tyrosine. Melanin, thyroxine, epinephrine protein, and tyrosine sulfate are affected. So melanin class, take note, is the pigment for dark hair and the skin. A defect in melanin class can cause albinism. Increased production of melanin naman class would cause malignant melanoma. There would be increased 5,6 dihydroxyindole. So this can cause dark urine from the oxidation of melanogen to melanin. Then we have your alkaptonuria. Now, alkaptonuria class is enzyme deficiency caused by a failure to inherit the gene to produce the enzyme homogentisic acid oxidase. So the problem with your alkaptonuria is that there's a deficiency in homogentisic acid oxidase, the third major defect in the phenylalanine-tyrosine pathway. Black alkaline urine and possible black stained diapers. It would manifest later in life with brown pigment deposits in tissue. Urine would be blue when added with ferric chloride, producing yellow precipitate with cleanitest, black with silver nitrate and ammonium hydroxide, and there's also quantitative tests that are available. Then we have your branch-chain amino acid disorders. So these are amino acids with a methyl group that branches from the main aliphatic carbon chain. So there are two types of branch-chain amino acid disorder. We have your MSUD. Early degradation products would accumulate. Then we have your organic acidemias. Accumulation of organic acids further down in the pathway. Ketonuria, it can cause ketonuria in newborns. So let's discuss your MSUD. So MSUD class is an inborn error of metabolism. It is inherited autosomal recessive. Amino acids involved in your MSUD are your leucine, isoleucine, and valine. 1 week failure to thrive is noticed. So urine would produce a strong odor of maple syrup and would have a thick and dark appearance. So para siyang maple syrup class yung urine mo. Very thick and very dark with a strong odor of maple syrup. Dietary regulation by day 11 shows good outcome. So if the patient or if the newborn is able to have dietary restrictions by day 11, the effects could be reversible. So positive urine ketones. Screening test class for this is your 2,4-dinitrophenylhydrazine produces yellow precipitate and turbidity. So this is your 2,4-dinitrophenylhydrazine test. So you would place 1 ml of urine in a tube, add 10 drops of 0.2% 2,4-DNPH into normal hydrochloric acid, wait for 10 minutes, observe for yellow or white precipitate. Then we have your organic acidemia. So there would be early signs of organic acidemia. The newborn would develop severe vomiting, metabolic acidosis, hypoglycemia, ketonuria. There would be different types of organic acidemia. We have your isovaleric, propionic, and methylmalonic acidemia. So let's discuss first the isovaleric acidemia. Isovaleric acidemia would produce a sweaty feet odor from the patient and is caused by the deficiency of the enzyme isovaleryl coenzyme A. Propionic and methylmalonic have no conversion of valine, threonine methylmalonate to succinyl coenzyme A. So the amino acids valine, threonine, and methylmalonate class cannot be converted to the enzyme succinyl coenzyme A, which is needed in this type of acidemia. Isovaleric, propionic, and methylmalonic acidemias can be detected by newborn screening programs using tandem spectrophotometry. Then we have your tryptophan disorders. Now, normally, class, when your tryptophan is degraded, it would be degraded into indole and excreted into the feces. But in some cases, class, in some disorders, tryptophan would not be excreted. Example, in intestinal disorders, tryptophan would be degraded into indole but not excreted. Remember, your intestines would absorb indole and would remove it via feces. But in intestinal disorder, the indole is not being excreted by the feces. So when that happens, there would be excess indole, and this excess indole would be reabsorbed from the intestine and would go to the bloodstream. From the bloodstream class, it would now go to the liver. In the liver class, indole is degraded into indicans, and indicans would be excreted via urine. Now, for you to identify if the patient has a problem or intestinal problem revolving your tryptophan, if your urine that is positive for indicans is exposed to air class, urine will become indigo blue. Now, if a patient naman this time has malignant tumor, your tryptophan would now become 5-hydroxytryptophan, leading to the production of serotonin and producing 5-hydroxyindole acetic acid, or your 5-HIAA. So increase urinary excretion of the metabolites indican and 5-hydroxyindole acetic acid. So these are the tryptophan disorders class. Increase 5-HIAA excretion, and indican excretion. So let's start with the high amounts of indicans in your urine, or also known as indicanuria. So tryptophan would enter the intestine, reabsorbed or converted to indole by bacteria, and lives in the feces. Intestinal disorders such as your heart-nap disease would cause tryptophan conversion to indole. Increased indole is reabsorbed, excreted by the kidney on its way to the liver. Exposure of urine to air would cause your urine to turn indigo blue. A known intestinal disorder known to cause indicanuria class is the heart-nap disease. Heart-nap disease is also known as your blue diaper syndrome. This is an inherited disorder affecting the intestinal reabsorption of indole and renal tubular reabsorption, leading to Fanconi syndrome. It requires a supplement, dietary supplement, which is used to treat it, niacin. So niacin is the required dietary supplement if a patient or a newborn has indicanuria. Then we have high amounts of HIAA. So tryptophan would produce serotonin. Serotonin from tryptophan is produced by the intestinal argentaphin cells and is carried into the body to the muscles by platelets. Excess is excreted in the urine as 5-HIAA. So argentaffen or enterochromaffin cell tumors would cause increased 5-HIAA in urine from excess serotonin produced. So the reason, class, why you have 5-HIAA, increased 5-HIAA, is because of a tumor, class. The tumor specifically found in your argentaffen cells. Now, due to this tumor in the argentaffen cells, class, this would cause the creation of increase or the increase in production of serotonin. And if there's too much serotonin, class, it would lead to increased 5-HIAA. So the urine test for 5-HA is nitrous acid and 1-nitroso 2-naphtol, which would produce purple to black color. Normal values is 2 to 8 milligram per day, greater than 25 milligram per day in disease. Can perform tests on random specimen. So patient instruction: no bananas, pineapples, tomatoes, phenothiazines, and acetylenides for 72 hours. 24 urine samples must be preserved with hydrochloric acid or boric acid. Then we have your cystine disorders. So there are two types of cystine disorders, and both have noticeable odor of silver. So we have your cystinuria. Now, cystinuria, class, is the inherited disorder affecting renal absorption. So there are two modes of inheritance. Only cystine and lysine are not reabsorbed, and the second mode of inheritance, cysteine, lysine, arginine, and ornithine, are not reabsorbed. Increased calculi formation early in life for both modes. Approximately 65% of the people in whom all four amino acids are affected can be expected to produce calculi early in life. Now, cystine is the least soluble, accounting for cystine crystals. Cystine is also the only amino acid found during the analysis of calculi from this patient. So, most of the time, class, kapag may cystinuria ka, yung kidney stones nyo are made up of cystine, or the renal calculi is made up of cystine. Now, urine screening test is the test known as your cyanide nitroprusside. So, sodium cyanide would reduce cystine, and nitroprusside would produce a red-purple color if there is excess cystine present. False positive is seen in urines with high amounts of ketones or ketonuria and homocystinuria. So yung sodium cyanide nyo, class, would remove cystine, and if there's too much cystine, class, in the urine, nitroprusside would turn it into a red purple color, which is the positive result for the cyanide nitroprusside test. So here's the step. So place 3 ml of urine in a tube, add 2 ml of sodium cyanide, wait for 10 minutes, add 5 drops of 5% sodium nitroprusside. Observe for red purple color. Then after cystinuria, we have your cystinosis. So cystinosis, class, is the genuine inherited metabolic disorder. So ranging from a severe fatal disorder developed in infancy to a benign form appearing in adulthood. So there are two categories: the nephropathic and non-nephropathic. Under nephropathic, we have your infantile and later life. Now, this is a defect in the lysosomal membrane, prevents the release of cystine into the cytoplasm for metabolism. Can lead to crystalline cystine deposits in the body. So if cystinuria, class, would only affect the urine, in cystinosis, class, it would affect the body, especially the kidneys and the cells. Now, there would be cystine deposits, class, found in the cornea, the bone marrow, lymph nodes, and other organs. Renal tubules are affected by deposits causing Fanconi syndrome, which is not inherited. In infants, there would be rapid progression to renal failure. So then on late onset, gradual progression to renal failure. For non-nephropathic, there would be benign and some ocular problems. For laboratory, there would be amino aciduria, reducing substances, and cystine crystals. Renal transplant and cystine depleting medications are used to treat this cystinosis. Then we have your homocystinuria. This is a defect in the metabolism of methionine. So there's a problem in methionine class, producing increased methionine in the body. Failure to thrive, so the newborn would be unable to survive. There would be cataracts, mental retardation, thromboemboli, and death. It would require a change in diet. Additional screening with silver nitrate instead of sodium cyanide is done, included in the newborn screening programs performed using tandem mass spectrophotometry testing. So this is the silver nitroprusside test. Place 1 ml of urine in a tube, add 2 drops of concentrated NH4OH, add 0.5 ml 5% silver nitrate, wait 10 minutes, add 5 drops of sodium nitroprusside. Wait, observe for the red-purple color. So this is the heme synthesis class. Now for heme synthesis, this is involving your porphyria. Now when it comes to porphyria class, there are different enzymes. There are different enzymes needed for the conversion. Now the heme synthesis would begin with glycine and succinyl-CoA. Now, glycine and succinyl-CoA would be converted into your gamma aminolevulinate or your ALA by the enzyme aminolevulinic acid synthetase. Now, gamma aminolevulinate class is further degraded or converted into the by aminolevulinic acid synthetase into porphobilinogen. Now, take note of this one, itong yellow na to. This yellow one class, this would occur. This would occur class if your aminolevulinic acid synthase is absent. If your aminolevulinic acid synthase is absent, it would produce a disorder known as your ALA hydratase deficiency porphyria. So take note of that. Ha? The cause of your ALA hydratase deficiency porphyria is your aminolevulinic acid synthase deficiency. Now, let's say normal class, walang deficiency dyan. Gamma aminolevulinate ALA is converted by aminolevulinic acid synthase into porphobilinogen. Now, porphobilinogen class would be converted to hydroxymethylbilane by the enzyme uroporphyrinogen synthase. Now, if uroporphyrinogen synthase is absent, it would cause the porphyria acute intermittent porphyria or the AIP. So, pakitake note yan na. Pakitake note class yung enzyme deficiency and the diseases it causes. Kapag absent si aminolevulinic acid synthase, it would lead to ALA hydratase deficiency porphyria. Kapag absent si uroporphyrinogen synthase, it would lead to AIP. Similar with the other class, if there's the absence of uroporphyrinogen co-synthase, it would lead to congenital erythropoietic porphyria. Absence of uroporphyrinogen decarboxylase would lead to porphyria cutanea tarda. Corpopyrinogen oxidase absence would lead to hereditary coproporphyria, and the absence of protoporphyrinogen oxidase would lead to variate porphyria. Then absence of the enzyme ferrochelatase would lead to erythropoietic porphyria. So kindly memorize this class. Memorize the enzyme. So ito ang technique dito ha. I will get questions from this picture. So memorize the enzyme. Memorize the disease caused by the absence of the enzyme. And I also want you to memorize what is converted by that enzyme. So example class, your protoporphyrin 9 is converted to heme by ferrochelatase. So tatanungin sa quiz nyo, what is converted by ferrochelatase. So it would be protoporphyrin 9 to heme. So do memorize that class. So let's discuss them in depth. So porphyrin disorder. So these are intermediate compounds in the production of heme. So we have primary porphyrins, which would include uroporphyrin, coproporphyrin, and protoporphyrin. Precursors is your alpha aminolevulinic acid and porphovilinogen. Detection of pathway disruptions in urine, blood, bile, and feces. So in the urine class, you would detect ALA, porphovilinogen, and urobilinogen. For the feces and bile, you could detect coproporphyrin and protoporphyrin. For blood, you would be able to detect free erythrocyte protoporphyrin for lead poisoning. So do memorize this class. Memorize the different porphyrins for every specimen or sample. Collectively, the term Porphyrias class, they are inherited. Gene and metabolic pathway is missing. Classified by clinical symptoms as neurologic or psychiatric, cutaneous or photosensitivity or both. So most of the time, class, kapag may porphyria ka, the most common and the most not severe is photosensitivity. Very sensitive ka to light, class. But in some advanced cases, porphyria could manifest as a neurologic or psychiatric disease. Then acquired porphyria is more common, usually in lead poisoning, alcoholism, iron deficiency, chronic liver and renal disease. Now, the characteristic of a porphyrin disorder is that you would develop a port wine color after air exposure, also seen on diapers. A test for porphyrin is the Ehrlich reaction. Ehrlich reaction class is only for ALA and porphovilinogen. It converts ALA to porphovilinogen by adding acetylacetone. Then we have the Watson-Schwartz test. This is an Ehrlich reaction now included on the multi-sticks urobilinogen plant. Fluorescence under UV light, 550 to 600 nanometer range, is used for other porphyrins. So UV light class set at 550 to 600 nanometer is used for other porphyrins. Extract it into glacial acetic acid and ethyl acetate. It does not distinguish violet, pink, or red based on concentration. Then we have the mucopolysaccharide disorder. So these are inherited disorders preventing the metabolism of glycoaminoglycans in the connective tissue. Incompletely metabolized polysaccharides accumulate in connective tissue. Substances found in urine are dermatan sulfate, keratan sulfate, and heparin sulfate. So we have here your mucopolysaccharidosis. So this mucopolysaccharidosis class is wherein your body accumulates so much mucopolysaccharides, and there are different disorders. These things are usually asked in the board exam, especially in your clinical chemistry class. So you will also encounter this topic in your clinical chem. So the polymicrosaccharidosis are divided into a lot of diseases, but let's tackle some of the important ones. We have the Hurler syndrome. For the Hurler syndrome, there would be abnormal skeletal structure, severe mental retardation, and corneal damage. For the Hunter syndrome, abnormal skeletal structure, severe mental retardation, inherited as a sex-linked recessive trait, very rare in females, and the Sanfilippo syndrome characterized by mental retardation. To treat mucopolysaccharide disorder, it would require bone marrow transplant and even gene therapy. Then urinary screening tests. So we have acid albumin and cetyl trimethylammonium bromide, or the CTAB. The CTAB turbidity test. It would produce a thick and white precipitate. Then we have your metachromatic staining procedure. So positive urine would produce a blue color that cannot be washed away with dilute acidified methanol. So this is the steps for your CTAB. So place 5 ml of urine in a tube. Add 1 ml of 5% CTAB in citrate buffer. Read turbidity in 5 minutes. Then we have your mucopolysaccharide paper test. Dip filter paper into 0.59% Assure A dye in 2% acetic acid. Let it dry, then add 1 drop of urine to paper. Wash with 1 ml of acetic acid plus 200 ml of methanol diluted to a liter. Observe for blue color. Then we have your purine disorders. So this would include the Lesch-Nyhan disease. Lesch-Nyhan disease class is an inherited sex-linked recessive disease. Massive excretion of uric acid crystal. Motor defects, mental retardation, self-destruction, gout, and renal calculi are seen. Normal development 6 to 8 months. Produces an orange sand color in diaper. Be alert for increased uric acid crystals in pediatric patients. Then you have your carbohydrate disorders. This is termed as melituria, frequently due to inherited disorder. No problems except for galactosuria. Three enzymes are used class. We have your galactose 1 phosphate uridyl transferase or your GALT, which is also included in the tandem MS screens. Failure to thrive, severe mental retardation, cataracts, and liver disorders would manifest on the newborn. To treat this class, you need to remove lactose from the diet. Included in newborn testing of RBCs. Clinic tests positive. Then other meliturias, we have your lactosuria. Lactosuria is seen in pregnancy and lactation. Fructosuria, parenteral feeding. You would use resorcinol screening tests. Then we have your pentosuria, ingestion of large amounts of fruit. So that basically ends your lesson 6.